Whether you're a parent navigating myofunctional disorders or simply curious about optimizing your family's overall health, the MyoHacker Podcast is your guide. Hi, I'm Karindy, a speech-language pathologist, myofunctional therapist, and a mom on a mission to bring holistic health to you and your family. Together, we'll explore whole-body connections and integrative solutions. Please subscribe and leave us a 5-star review to help other families discover this important information. Visit MyoHackerSLP.com for free resources and guides. Quick disclaimer. The content shared in this podcast is for information and entertainment purposes only. The views and opinions expressed by the host and guests do not necessarily reflect those of the podcast or its affiliates. This podcast does not provide medical, legal, or professional advice. Always consult a professional regarding your circumstances. By listening, you agree that the host and podcast are not responsible for any actions you may take based on the information provided. Now, let's dive into today's episode. Welcome, everyone, to the MyoHacker Podcast. With us today is my dear friend and previously my supervisor, Jean Hawney. She is an incredible speech-language pathologist, myofunctional therapist, feeding therapist, and just a spark plug. If you meet Jean, you will be inspired to take action, to laugh really hard, and to be very present in the moment. I learned from her back when I was in my CF, my clinical fellowship year, and she took me under her wing, taught me so much. And the biggest thing, well, there are so many things that Jean taught me, but I just want to say she taught me how to have just like light and love and fun in moments when it could be heartbreaking, like working with families that were going through the hardest seasons of their lives. And she brought so much joy and enthusiasm to it, and she still does to this day. So welcome, Jean. Tell everyone a little bit about yourself and some of your training so they understand how dynamic and strong and beautiful and amazing you are.
What an intro. Yes, I am Jean Hawney. I am a speech-language pathologist, board-certified swallowing specialist, certified lactation counselor. Gosh, I think I've been doing this for maybe almost 15 years now, working in a lot of settings, but in the last 2 official years, I am now full-time working with my business, Little Eaters and Talkers, where in the Houston area and then virtually providing feeding and swallowing speech. And we have occupational therapists that help our littles learning how to breast, bottle, transition to solids, picky eating, all the things in the area.
So I want you guys to know that Jean has worked with so many different types of patients with medically complex issues. And when people reach out to me now asking for support for their tube feeders, we're going to talk about the different types of tubes that there are. And really, they're trying to transition to solids. They've had difficulties with swallow studies. If they're not already working with one of the, outpatient clinical settings that we have here in the Houston area, we do have quite a few. I'll just be like, why aren't you working with Jean? Go see Jean. And I love being able to refer to Jean. So I would love for you to talk about that. What are some of the different types of tube feeding options that families have when they see you? And how do you work with them on transitioning safely to more of an oral nutrition intake?
Okay, so lots of variables, right?
Yes.
Because if we start with our babies who discharged from the NICU with whether it's a nasogastric tube through the nose or a feeding tube, a G tube in the stomach, there's a lot of processing of that journey.
Yes.
Of what those parents and those babies have gone through, trauma, so much trauma. And I feel like so many of them, when they get to me after they've discharged, because they have a feeding tube, they're still kind of working through a lot of the GI stuff. Because you have to think about it like, yeah, you were a NICU baby, but what led you to needing a feeding tube? And sometimes it's aspiration, but more often than not, I feel like our speech pathologists in the hospital are pretty good about navigating the aspiration world to make feeding safe. But ultimately, it leads to, what your GI system can tolerate and then the weight gain.
Mm-hmm.
So, and then of course, underlying comorbidities, right? Are you a cardiac baby? Are you have Down syndrome or a rare genetic disorder? Or are you just a preemie that came too early, right?
Yeah.
So those variables are really going to help us figure out what our goals are going to be and how to get there. Unfortunately, some of our babies who had prolonged hospital stays, who are now on feeding tubes, ultimately, like, are they even eating at all? Right? Are they coming to me like totally NPO? Are they doing some non-nutritive breastfeeding? Are they bottle feeding? Ooh, so sometimes I'm literally starting from zero and the suck reflex is gone. So in those cases, I never dismiss the bottle or the breast if a mom or a caregiver wants to work on it.
Mm-hmm.
I am game for it, but ultimately I try to explain to parents the bottle and perhaps the breast is a phase, right? Like, we are not bottle drinking at 5, 10 years old. We
Mm-hmm.
want to be eating.
Mm-hmm.
So I want to get them learning how to love to eat.
Yes.
And that is going to be the most important for me. And again, I'll still work on bottle and dibble dabble in that and make sure, of course, if it's a swallowing issue, we'll work through whatever that entails, whether it's thickening or different nipple flow rates and making things safe. But if we're getting close to like that 6-month mark or
Mm-hmm.
so, I really want those babies getting strong with their PTs and OTs, and some of them I have seen chiropractors as well,
Mm-hmm.
to get them ready for oral eating.
Yes.
Right? Like, isn't
Yep.
that the most fun part?
Oh, for sure. Getting that collaboration, getting them ready to transition out of just that suck swallow phase into now what are the oral motor components that they need to have organized, safe feeding. And really, it's now, in this myofunctional space, because I know you and I both were in that thinking of dysphagia, just swallowing, more of a, penetration aspiration perspective. And then you and I both got into myofunctional therapy as it relates to supporting craniofacial development, a wide, healthy, functional airway, all of these things. That's where we really see the power hitters of being able to chew adequately on both sides, even though you might not have teeth yet. If you've got that phasic bite, what are the reflexes that we can use to support that development? So talk to us a little bit about when you see these kiddos that don't have, like you said, maybe that suck reflex is just gone right now. They've been through a lot of trauma. Their nervous system has been through a lot. What might it look like in those sessions when you're helping kiddos bring these reflexes kind of back on board? Or maybe they don't have them. How are you going to help them with with navigating some of these oral motor skills?
We have to start with some of the basics.
Yeah.
And when you have a baby who has been in the hospital so long,
Mm-hmm.
oh my God, many therapists and parents are focusing on, the volume in, the bottle. They're not always making it a positive experience or
Yeah.
even doing intraoral stimulation, getting in a baby's mouth and just playing in their
Yeah.
mouths.
Yeah.
And sometimes that's where I need to start, right?
Yes.
There's
Yeah.
so much negative experiences with the face. Some of my babies who have had so much taping of the NG
Yeah.
tube and you can't touch their nose.
Yeah.
So,
Or just even the gloves. They see those gloves go
oh
on
my
and
God, I absolutely. And oh my God, it's so horrific.
yeah.
So a lot of times it's like working through touch,
Mm-hmm.
the power of touch. Isn't that a
Oh,
beautiful thing, right?
yes.
And like, how many parents tell me their 2-year-old who had traumatic events as a baby won't
Mm-hmm.
let them brush their teeth,
Yeah.
right? And then you're like, well, we have to brush our teeth. Like we have to figure out a way, but why did
Yeah.
it get to this point? What could your feeding of therapist have done early on to create positivity in the mouth, even if you are not eating by mouth?
Yes. Yes.
Like,
So just
oh my gosh, that's a huge component. And it doesn't have to be these exercises of like 5 circles on this side and 5 circles on this side. Like, just getting in there and like moving that tongue and biting on fingers and biting on chewy tubes. Like, I promote so much of pre-feeding readiness of like, right, using chewy tubes, using your mommy's finger in your mouth, doing breast milk pops or smoothie pops. Yeah, those positive oral experiences. And I've had so many babies that were stuck in the NICU for so long, and I'll say, did the therapist teach you how to do any stretching in the mouth? There wasn't time for it.
Right.
There was no time. And I'm not blaming a therapist. I'm not blaming a parent. It's just we lost time that we now have to make up.
And I think there's beauty to the opportunity that they have in working once they get outside of, the hospital setting. Now we are more medically stable. We're in a different place just from a, nervous system standpoint, from an energy standpoint. Initially in those phases, that might not be the best use of energy output. They're just working so much on digestion and sleep and healing and getting to a baseline. Now, once they get outpatient in an outpatient clinical setting like we have, now we can work on some of these things, including, which we were talking about this a little bit beforehand, baby-led weaning. I wanted you to talk about this from the medically complex standpoint, because you and I both see wonderful families who are holistically educated, like they understand the importance of a baby-led weaning approach for development of, craniofacial dental structures. But there are some things to consider in these medically complex contexts. So can you talk about that?
So with our more medically complex baby, things that we often find is caregivers and medical professionals being so over conscientious of weight. Wait. How much are you getting? How much are you getting through your feeding tube? How much are you eating by mouth? Right? It's like this. So that's a huge part of a barrier that I sometimes have. Because I'm like, you're so hyper-focused on weight, but it's not positive. It's not happy experiences. The other thing I find that is another barrier is in addition to the weight gain, it goes along is the volume and pushing of formulas and milks as your base to thrive, right? And you think about it, you're like, for a neurotypical child, when you hit 12 months, you should be weaning off of formula. You could be doing breast milk ad lib, like when you want, but you should also be eating a lot of foods and drinking water. And so many medical professionals really are like, no, you're 12 months. Let's keep doing all this formula. Let's fill your belly with formula. And, and I think there's a place for it. Absolutely. Supplemental nutrition it can be so important. But when we talk about mind-body connection for these little people, they learn, wow, that milk is what fills my belly. Right? They're not learning that food fills my belly. And I'm doing some experiments right now with some of my babies who are on the low end of weight, but they're gaining, they're stable. But now they're taking off on their foods. And now they're finally jumping percentiles. They're jumping percentiles.
Oh, are their families just so
they're
happy
like, how? And they have to really trust the process because they're being told, no, you need 30 ounces of your milk. And I'm like, but what if we can maintain our weight and be hydrated, but really work through the progress of like higher calorie, nutritious foods? And let's see what happens. And I have a few families that are really trusting me with this and working with a dietitian as needed. Sometimes the dietitian is not in agreement. And we have to find someone that's willing to work within our model.
I have so many memories of you like fighting with dietitians.
If I could go back in time and redo,
me too.
I love my life
I know,
and I love what I've done, but like I would love to be a speech pathologist dietitian.
Oh, that'd be amazing.
I would love that. It's just,
hours
we're
in a day.
tired.
Yeah.
But like I really promote holistic
Yeah.
food introduction. So back to your thing about like neurodivergent kids and feeding tubes, when they turn a year, if you're in my office, I'm hooking you up with my favorite dietitians that are going to promote food, whole food blending and getting foods in through the G tube.
So real quick, for someone whose ears just perked up, what are some resources? They're like whole food blending. What do I do? Like maybe just some places they could go to get more information on this?
I mean, my number one person is Hillary, the tube feeding dietitian on
Love it.
Instagram. She
Love it.
is beyond so helpful. We've shared a lot of clients and she helps me, I help her.
Yeah.
And she comes up with these incredible ideas. You know, if you're a cardiac baby or you're nutrition deficient, she will help come up with recipes that you can put through the tube
Yeah.
to build that. And then guess what? We can eat it versus like you putting alpha-amino in a tube. I'm not drinking that. Well, and that's another thing, Karindy, that I've been having some issues with is when doctors and dietitians, no offense to them, I love everybody, but like if you are pushing an 18-month-old to stay on a toddler formula or an infant formula that is very acidity or a pure amino or an alpha amino, not even teeth, your taste buds.
Yeah.
So then it's like, I want to work on bananas and the kid's like, what the heck's that? I'm not eating that. Give me my pure amino.
Yeah.
And you're like, I had a conversation with mom. I was like, what does pure amino taste like? Like, let's taste it. And I was like, I don't know. And she was like, well, it's kind of seaweedy.
And an umami tinge.
Yeah. And I was like, well, then should we be eating seaweed all day? Like, how do I translate that formula that has such a distinct taste to food? And if your mind body is saying the pure amino or this formula is what fills my belly up, like we have to work on that.
So what does that look like? They come in, they see you, take us through maybe a couple of months or a couple of sessions. It doesn't even have to be like the full thing, but maybe what might
How
that
old
look
is the
like?
kid?
Let's say an 8-month-old.
Okay. So I have some babies like this now who have feeding tubes, and you know, our primary diet, yes, is the formula or the breast milk. I am not your GI doctor, but if you are super uncomfortable with your feeds, we need to get our GI in check.
Right.
So I will have parents get second opinions or third opinions to find a GI doctor that will kind of work with us a little bit better, whether that be changing the formula, going hypoallergenic as a more holistic professional. I don't know what you think, but like, I love European formulas.
Yes.
Shoot me. Like, I can't stand that the first ingredient is corn syrup.
I know.
I just can't do it. And so if I have a baby and a parent is knowing that the GI tract is still not in check, I'm like, let's have a conversation about your formula.
Yeah.
And some are willing to change and some are like, I've got 4 months left.
Yep.
And we're just going to ride it out. And I'll respect whatever your decision is.
And this is the barrier we run into when it comes to like insurance, what is covered and what is not. And what is covered is high fructose corn syrup. What is not are going to be, like you said, these European formulas, these, things that are, you can tell they came from Whole Foods. Like if it's not formulated and synthetic, it's typically not covered. So
But if your
tricky.
GI system is still like, if you're still struggling with the reflux, intolerance, vomiting, like we're not going to make progress until that stuff is resolved.
Yeah.
Like one of my little guys, he got a little sick and he was vomiting so much. He had not been gagging for weeks in our sessions. And then all of a sudden it took us like a month to get over his hypersensitive gag from just getting sick.
Yeah.
And throwing up all his milk. But you see, like, it's like step one is like GI check. You can't even get in a mouth if you're throwing up all the time.
For sure. Nor should you. Like your body is sending a signal that something's on fire. We need to take care of it. So the body is naturally saying, stop, listen to me. Like peristalsis or something is off. I need help. And so that is this tricky line of going, we've got to walk this. We've got to work with the GI. We've got to work with hopefully a body worker, someone that's going to help with movement, getting the sacrum involved, getting just, because it can be also just that discomfort kicks in when we have muscle tone and things shifting in the GI tract itself. That can change how the body's even responding to the pH changes, to whatever we're ingesting. So there's so much too that we can do on the outside, but ultimately we do need that support, like you said, with the GI, with the support of the doctors to get digestion back on track, or at least, on the track somewhere.
Right, because if a parent will be like, why isn't my kid eating? And I'm like, they can barely tolerate the milk that's going in their belly. So that, and I really try to get my parents to advocate. So I tell parents, unfortunately, I find with a lot of our medical professionals, it's a lot of like, blank darts, right? Or however you say it, blank bullets. Like, let's try this. But if you don't try it, you don't know if it'll work or not.
Right.
So if I get an 8-month-old and our digestive system is in check, then we go through our routines. I often have to remind parents, they're flying by the seat of their pants. They are exhausted.
Yes.
But routine is so important. And, whether you have a nanny or you stay at home or your kid goes to daycare, we need to be consistent with our schedules. But also, what does hunger look like? Right? If you have a feeding tube, most parents don't know what hunger looks like.
So what are some signs? What should they look out for?
So oftentimes, I can't tell you how many times I have 8 to 12-month-olds that are still on a newborn feeding schedule.
And take us through. What are some
hours,
schedules?
Every 3 hours, day and night. Every 3 hours, because Karindy, they got to gain weight.
Yep.
And they might be sleeping for 6 of those hours at night, but they're still getting two feeds. And parents, like, even with my kids that don't have feeding tubes, I often find parents go, my kid's not transitioning to solids. And I'm like, well, what's your feeding schedule like? Like, your baby's 9 months. Why are we still eating every 3 hours at night? We have to rest and digest, right?
Yes,
like, if you don't rest and digest, you're not going to get hunger. So again, it'll go back to a conversation of like, can we talk about spacing these feeds out? Can we talk about eliminating a feed in the night? Right?
I'm curious. This is literally just a question I'm thinking of. Are there studies specific to leptin and ghrelin in like tube feeding schedules and how they're affected versus like comparing it to breastfeeding? Do you know if we have any studies like this?
Oh, I don't know, but I just think about all these crazy schedules that people give to parents, and then they expect their kids to eat. Like, one that I used to fight with people all the time about, the continuous at night.
Yes.
And it'll be like, well, we'll give Johnny all day to eat. And I'm like, but
He's
you
so
just
full
fed
in the
him
morning.
30 ounces from 6 p.m. to 6 a.m. He's not going to be hungry again until 6 p.m. So we just like destroyed our whole opportunity of working with a feeding therapist because you had to get your calories in.
Yeah.
I mean, that's painful. Like, eating in your sleep is not natural.
Yeah.
And there are situations where, if we talk about bottle aversion, where you might have some dream feeds, but you should not be feeding your baby day and night when they are asleep.
Speaking of, let's talk about bottle aversion. You have a course out. It's on your website, right? So talk to us about this and, what is it in your course and how do you work with families who come to you with this issue?
So I would say the majority of babies that I get with bottle aversion, they're usually coming to me after their 4-month or 6-month pediatrician appointment. Because those are when things have like gotten out of control. And then I also see things that, made it worse after that visit.
Like what? Can you share?
I can share, and I will preface to say, like, I love my pediatrician. I work with a lot of pediatricians. I just think that if you have a more sensitive baby, we should be more sensitive to that baby And I think some people have their agendas of like, you're here at your 4-month, you're going to get these vaccines. This is going to be my roll call. And then I'll see you in 2 months.
Mm-hmm.
Right. And then, but if you're going into that 4-month or 6-month appointment already like hating feeding, hating your bottle, or parents are using every method to get you to eat, dream feeding, distraction, feeding in a dark room day and night, like the baby can only feed with one person, or they are feeding while being walked around a room. I mean, there's some really interesting things that parents have to do, and I get it, survival, but it's not sustainable.
Yeah.
And then sometimes when a baby gets sick, so whether it's like the vaccine side effect,
Mm-hmm.
or I'm like,
We're
you
not
don't
going there.
you don't feel good after you get a vaccine.
Yep.
Some babies respond fine, but if you're more sensitive, you feel it differently. And
Mhm.
I'm okay with it. It's just I would rather space them out for some of
Yep.
my babies, but
Yep.
also teething or getting a cold. Like these babies shut down. Like you
Yeah.
said, they go into like hyper mode of like not being able to process their world.
Yes. Yes.
So with those situations, another big one that I'll often see is when babies start daycare
Oh,
or
yeah.
with a new feeder. And I explain to parents, like, I get it. You got to go to work. I got to go to work. But what is the one job of the daycare or the nanny? It is to feed your baby.
Not to prop it up, not to prop up a bottle with some cushions and
I mean, not usually. In daycare,
Yeah.
you can't do that. But it's like a mom says, I just pumped this 5-ounce bottle.
Yeah.
Make sure Johnny gets this 5-ounce bottle. And this nanny's one job is to get Johnny to drink this 5-ounce bottle.
Mm-hmm.
We don't know how, when, where, what. And then that cycle starts to lead to negative associations to eating.
So what are maybe some tips? People, now, obviously, seeing you would be tip number 1, but I have people that listen from like the middle of nowhere. What are some tips that they could try right now to transition and get a little bit more acceptance with the bottle?
So I have some babies that come to me that all of their feeds are while they are asleep.
Mm-hmm.
So we need to work on eating when we are awake in the day. When you've lost your reflexive sucking at, 6 to 8 weeks, somewhere around there, you have to learn how to eat when you're awake so that feeding feels good. You integrate it, right? To being actual skill.
Yeah.
And if you continue to rely on dream feeding, then you're not building the association of, I have to eat when I'm awake. I eat because it feels good.
Mm.
But parents get desperate about weight gain and volume, and the only way to get it in is when the baby's sleeping. So, number 1, we talk about what is a practical way in your home that we can be conscientious of our weight, but also allow the baby to lead the way to feed when they are awake and respect that baby. So I have a lot of people who get so nervous and they're like, but he only drinks 30 cc, 1 ounce when he's awake. And then I just give it to him when he's falling asleep. So we have to work through some of that of, well, how can we build our volume up when we're awake? How can we make it more positive? Another thing that we'll have to do a tip is like, it's really, really hard, but I have to look at all the distractions that you're providing,
Yeah.
and we have to somehow remove some of them.
So why? Why do they need to remove some of these distractions while they're feeding?
I mean, can you imagine feeding your 5-month-old with your cell phone of Coco Melon?
Yes, yes.
Like, that's not a good habit.
Right.
That's not a good habit that we want to teach our babies, that they have to eat with a distraction. Think about your toddlers that only eat with an iPad in their face.
Yeah. Yeah.
We're teaching them from an early on that the only way to eat is with a distraction.
And
How
with
do you
disengagement from the body.
And then there's no mind-body connection there.
Yeah.
You're
Yeah.
mindlessly eating.
Yeah.
Which
is crazy because even though right now at this young age they might have a weight gaining issue, if we are mindlessly eating and not connected to our bodies, in the end it will lead to obesity. it leads to this. It can lead to this
Ooh,
just,
sometimes it's obesity and sometimes it's this severe control
yeah,
that children have over their parents, and they just have never learned how to enjoy meals,
yeah,
right?
yeah.
And then you're like, the patient this week, I was like, well, when do you go to a restaurant? She's like, why would I ever take my kid to a restaurant? That sounds awful.
Oh,
And
yeah,
then you're losing all that social interaction.
yeah. Okay, so
So
someone's listening and they're like, oh no, what do I do? What are some ways that they can start reducing the distractions?
we start in the day,
Yeah.
right? I'm
Yeah.
not telling you to take away some of the night feeds yet.
Mm-hmm.
But if
Mm-hmm.
you're awake in the day and all, we don't eat in a dark closet
Yeah. Yeah.
in the daytime, right? At night it's dark out. So we have to keep some variables the same. I try my best. Like I will, because I'm a speech pathologist, I can look at oral motor skills,
Mm-hmm.
right? And sometimes it's an easy fix. I wish they were all easy fixes of you're
Yeah.
like, why are we 4 months still on a preemie nipple?
Yeah.
Right? Like something logical like that. But that's not usually the case. Normally, the case is parents are skipping levels of nipples
Mm.
to give the baby faster flow, and the
To get it
baby
done.
is regressing because of
Yeah.
it. So, as a speech pathologist who knows a lot about oral motor skills, I do need to assess the oral motor and help parents determine, like, is this the best bottle? Is this the best flow rate? Right? And then
Yep.
I try my best to not make big changes for that. And I also want to preface, bottle aversion is different than bottle refusal. Refusal is a breastfed baby who refuses the bottle,
Yeah. Yeah.
right? So you don't use these same tactics for that baby. That is a different baby. That's a different breed.
You're
That's
right.
a baby. That's a baby
That's
who
not the same
loves
medically
the booby.
complex case.
No.
No, that's
No.
not. They haven't
That
had
is
an
just a
NG tube.
booby
Yeah.
baby, and mom has finally figured out that she wants to have that baby take a bottle sometimes.
And that's usually right before work or whatever,
Super
a
stressful.
vacation, something, and boom.
Yeah. So my
Yeah.
techniques for bottle refusal, which is the booby baby, is
Yeah.
way different than bottle aversion.
Yeah.
So I never want someone to use the same techniques for both. Because
And
they're
thankfully,
different
there are a lot more
breeds.
people, I feel like, that are informed in regards to that, in regards to bottle refusal versus, these kiddos that have aversions because of medically complex histories. Like, those are different scenarios. And depending on where you're at, you might be seeing more refusals versus aversions.
Right.
You know?
Or where the baby was born in the line of siblings.
Yeah.
Right? Like
Yeah.
sometimes I'll see it how it varies. Like first baby was really hard to breastfeed, second baby's better to breastfeed, and so mom is loving it, and then like
Yeah.
loses track of time, and you're like, oh my god, I'm going back to work and I haven't done the bottle.
Yeah.
Right? But that's bottle refusal. With bottle aversion, you say medically complex, and Karindy, I gotta say, I have so many babies right now that are very normal, born full term, weighed a good amount, and they develop bottle aversion.
Yeah.
And sometimes it's personality.
Mm.
Yeah. And I want to say, like, I get more girls than boys personally. And I think just, girls want to be in control.
Hmm.
I don't know. I mean, this is totally like I talk about how boys are different eaters than girls a
Yes.
lot. I don't think
Yeah.
there's research. It's anecdotal, of course,
Yeah.
but personality wise, like think about your babies. When your babies are born on day 0, they still have some of those characteristics today
Yeah.
as like 6 and 9 or whatever, 6 and 8.
Yeah.
So I know. So a lot of times with my bottle aversion babies, I tend to warn parents as we're making like really great progress. I'm like, you're going to have a feisty little one.
Oh no.
You're going to have a spitfire.
Yeah. Yeah.
And but that's okay because we know, at least we're
Yeah.
aware it doesn't come out of nowhere. And then
Right.
you're like, you were always so feisty. But it's parents learning to like let go a little bit
Yeah.
and not being so in control. So yeah, some of it's going to be like working through those distractions, not all at once, not changing too many variables. As a speech pathologist, yes, I can assess your bottle skills and help you figure out if that's the best bottle for what your mouth is doing. I do kind of really dig into like, what is the milk that we're giving this baby?
Yeah.
I had a baby recently on Nutrimogen, and they tried it, and baby broke out almost like in a full body rash. And everyone was like, well, you should try it for another week. And I'm like, please, no. Like,
why would they?
I
Okay.
know,
If they're breaking out, their body is saying something.
You talk about it too. Like, how expensive are formulas?
Yeah.
How many cans did you just get? Like, how do you just
know.
like, it's not easy for everyone to just change a formula.
No, it's not easy for anyone.
It's really hard.
Yeah. So I do want us to talk about oral aversion after a tongue tie release. Let's go there.
Well, that ties into some of my bottle aversion babies.
Yes.
Because like I said, I'm getting so many babies at that 4th and 6th month appointment. And I go back in their history, and so many times parents nonchalantly will go, oh, well, yeah, like he had his tongue tie, he had his frenectomy lasered at 4 weeks. And I'm like, wait a minute, what, back up here.
Yeah.
Like, talk to me more about this.
Yeah.
Why, what, how, like, what happened after? Was the baby ready?
Guys, let's say this real quick. Please do not get a tongue tie release for your baby if you are not working with a team. And it shouldn't just be a dentist or an ENT. It should be a team, like working with them on their oral motor, like activity, engaging the brain to the tongue, showing you stretches, showing you how to navigate the feeding changes that occur. Because when you change this structure that is at midline, it affects things. And literally today I had a message on Facebook from someone. They're like, hey, do you have any recommendations for someone in Georgia? We got a tongue tie release and we'd like to work with somebody on some stretches. And I'm like, no!
They already did it. They're already past the release.
Yeah. And they don't have a team.
Yeah. But also related to bottle aversion, which is often misdiagnosed for tongue ties, constipation, reflux, CMPA, cow's milk protein allergy, until parents have done the tongue tie release, changed the milk, put them on reflux meds, did a swallow study, and none of it fixed it.
Yeah.
And then that's what I mean. That's when they find me and they're like, we've done all of this, which to some extent helps me because it's already kind of taken out some of the problem solving.
Yeah.
And then I'm like, okay, we're staying stable. Like, we're not changing anything, including medication. Like, if your doctor puts you on meds, we do not change a thing. But yeah, going into a frenectomy, like, yes, I know that we see that sometimes when you're swallowing air from having a tongue tie, you might be more gassy, you might be spitting up more, you might be having hiccups, discomfort. But like, as a feeding specialist, I feel like I've been doing this long enough that I can see the difference between really the anatomy causing an issue versus like other underlying issues. Right? And then you're going into a frenectomy with the underlying issues still on fire.
Yeah.
The frenectomy is not going to fix that.
So many of those issues, we're seeing more and more of these mast cell activation syndrome kiddos and more just EOE, eosinophilic esophagitis, which can be related to the mast cell activation. Like, there's so much of just our bodies are under such a toxin load, so much stress, what mom went through during pregnancy, and it's carrying over into the cellular activation throughout the body. And so then, sometimes we're trying to throw a structural shift to see if that's going to help what is kind of a cellular metabolic mitochondrial issue that we need to calm down first.
Yes. But then you have all these parents and doctors, like the professional that's like, well, we need to fix this tongue tie right now and everything will be fine.
Yeah.
And then, as I mentioned to you previously, like, I'm not getting these babies till after it's done.
Yeah.
I do see some babies through frenectomies, but oftentimes their first person that they're seeing is the lactation consultant. And I love a lot of my lactation consultants, but that doesn't mean they know everything.
Well, and even, because I know some that are just incredible lactation consultants, and they're, fabulous, but they have done a ton of training.
Yeah.
A lot of training, and not every IBCLC has done training specific to tethered oral tissues. You can do that and not have extensive training in that. And that's why there are There are a few that I refer to and I collaborate with, and I love working with them. And then sometimes I will see babies that have worked with others, and I'm like, oh, I guess they didn't get support during that release.
But then what about the professionals, the IBCLCs that don't have the experience working with, bottle feeders or babies with GI issues?
Thankfully, the ones I work with do, but I often see patients. So because that is something you and I are different on this specifically, I make sure that patients, if they're going to see me under 6 months of age, I always say, I want you to work with an IBCLC because you love bottles, Jean. You love them. I'm like, I'm not sizing your nipples. I'm not doing these things. So I work with the IBCLCs, but sometimes if they'll tell me like, I've already worked with an IBCLC. I'm not interested in working with one.
I get that.
And they're not working with one of the ones that I recommend. Then I'll be like, okay, let's come on in. Let's see what's going on. Typically in those cases, there is something going on from an oral motor organization standpoint, an inflammatory response, a GI response, or all of the above. Like there's often, and fascial tension. There's often a lot in regards, these bodies are just tight. In those cases, I will take over, but I want them working with one of my preferred IBCLCs, but often they've been burned. They're like, no, I don't want to see another one. And so then I'm like, okay, let's see where we can get, or see if they're 6 months old, there's not necessarily a need for them to be working with them. But if there's 3 months old, then I'm going to see, like, where are we at? Okay. Since I don't specialize in the bottles, that's why I'm like, no, I want them working with them.
I do specialize in bottle feeding.
Yes. And that's why
and so
you have your bottle aversion course.
My take is like, I will say to parents, I'll get calls of like, I'm about to have a baby. I would love for you to come. And I'm like, You know what? I would really love for you to see some of my favorite IBCLCs. Yeah. They can work on the 101 latching, positioning, nipple pain, the pump, all of that.
Yeah.
But if you run into more complex difficulties, bring me in. Like that's when I'm like, okay, this is where my skills are really going to come to use.
Exactly.
Especially when you have airway stuff also, which, whether it's laryngomalacia or reflux or aspiration or, neurological stuff. Like I think we have, as speech pathologists working with medically complex kids, we can see those things
for sure
pretty quickly and not brush it off. And that affects your breastfeeding journey as well.
Yes.
So in those situations, I just try to really work with my parents of like, if we can do a dual system, like, let's do it. But, fed is best.
Yeah. So guys, if you're listening to this and you're confused, you're like, wait, so I've got a baby. Do I see an IBCLC or do I see an SLP?
Depends
like, who do I see? And so that's literally what I want you to hear in this conversation between Jean and I. Jean does specialize in bottle feeding. I specialize in oral motor, but I refer to the IBCLCs up to a certain extent. So this is where you kind of need to see where you at, who are the people near you, and then like, for me, I don't take insurance. So I'm going to say maybe start with this person who does in this setting. And then if you need more complex care, then let's talk. Then that might be a better fit. But that's where it's so individualistic with a treatment plan and with setting up your team, which we don't want it to be overwhelming. So let's break it down. Let's say your kiddo is getting ready for their frenectomy and things seem to be online. In this case, we're going to want you getting body work, working with an IBCLC who is trained on tethered oral tissue. So ask them about that. If they're like, I think it's a fad, hang up and talk to somebody else. Hopefully your release provider has a recommended group or, different people they're working with. And you want to have specific providers like an IBCLC, not just like a practice. Like you want to know, who do I work with? So you want to have that. But let's say maybe there are some complications. They had a swallow study and it showed that there was an oral phase issue that also led into pharyngeal phase concerns. This is where you might want to be working with someone like Jean. So she's an SLP feeding specialist and she does specialize in the lactation side. That's going to be where you want that specialized interest in a way, it's not that it's overkill. It's just like, okay, you can take it to the next level if you need that level of care. And this, then as we get more complex feeding needs, as they're older, we might want to work with an occupational therapist that can work on some of those feeding aversions, those kinds of sensory needs once we get a little bit older. So there's kind of this spectrum of providers, and this is where it can be tricky to find who you need. But I would say, thankfully, if you connect with someone like me, like Jean, we're going to talk to you about look, see these providers. We're busy enough. We're not trying to take on these patients. We just want to help families.
And I do help parents a lot, or being a second consultation, right?
Talk about that.
I don't know if this speech pathologist or occupational therapist or IBCLC is doing the right thing, or I'm making really slow progress. Jean, can we do a consultation and figure out if there's something else that can be done? Love those. And if I can help guide the therapist you're using, and as long as that person is open to it, I love coaching other therapists. I'm not here to take your patients. I'm here for the patient to do better.
Yeah.
There are some therapists that are like, no, my way or the highway. You only work with me. And then, that's not always a
I will
good
say
fit.
there is something to, when you have a lot of voices on the patient care, that can be overwhelming as a person.
Parent,
as a parent, taking that information in. But I know Jean and I both have sought out mentorship, and we always are seeking out specialists, people that can teach us skills. We teach skills, but we're also knowing our skills need to develop. So as providers, we always want to be in this place, how can we improve our skills and help these families? So just know that as a family, if you're this is overwhelming, too many voices, there is a purpose to sticking to kind of a one treatment plan, but a consult is never going to hurt. And especially when you can build in some of that mentorship like Jean does with different providers. It's
collaboration is totally what I love to do. You have a beautiful bubble that you've made with your lactation consultants.
Yes,
but not everybody has that.
I know.
And there are some incredible occupational therapists that work with babies in bottles and speech pathologists. And so I would not limit my babies who are getting frenectomies to just an IBCLC.
For sure. No,
who are bottle feeding.
No,
if these
for sure.
parents are exclusively breastfeeding, I am hold hands with that IBCLC and let them take you through that journey. I don't want to get involved. But if you've given up on the breast and now you're okay, I'm on to bottle feeding and transition to solids soon after, I think I have this kind of discussion with people about our physical therapists, our body workers, and our chiropractors.
Yeah.
And how different they are. Their training is different. If your baby needs to learn how to walk, for sure your chiropractor can help you. Oh my God, they can be huge help with so many things. But also you should actually have a PT or someone like that on your team.
Yes.
For me, right?
Yeah.
But I've had chiropractors tell parents, you don't need a PT. I'll teach your baby how to walk. And I'm there's just different schooling and different background. And the same goes for speech, OT, and our IBCLCs.
Yes.
But just
even
you said,
some of the
and
some of the PTs now that are doing some of the different trainings even.
Oh, yeah, and getting in the mouths, too.
Yeah.
But at the end of the day, this very much recently happened where a baby was seeing PT and she's like, I'm getting this baby for frenectomy, I'm getting in her mouth. And I'm like, but have you seen the baby eat?
Yeah.
And it's like, no, I don't have time for that. Why would I see the baby eat? And I'm like, oh my God, we have to watch this baby eat. Or I've had calls where babies go in for a frenectomy who have never had the bottle. They've only had the breast, and things go south. And I'll talk to the lactation consultant. I'll be like, well, did you try the bottle before? And it's like, no, that wasn't my goal. My goal was only the breast.
So let's talk to, let's say there's an IBCLC who's listening, and she's like, when would be the time that she's going to refer to the speech language pathologist?
Signs
as an
of bottle
IBCLC.
aversion, for sure. I mean, which usually happens after a frenectomy. It usually happens after because of all the trauma
Mm-hmm.
and the
all the
baby.
stretches and everything.
Oh my
Yep.
God. Yeah. And like weight is going down, volume is going down, stress is going high. They're relying on dream feeding, distraction methods. Like,
Mm-hmm.
please refer, please, please, please. And not just to the GI doctor, because a lot of times they put the baby on reflux meds and change the formula, but the behaviors are still there. The trauma is still there. There's a way to change, it's a behavior for that. Maybe if we are still, frenectomy went fine, but now baby's transitioning to solids and they're very gaggy and parents report they're vomiting with solids. Like some of my IBCLCs are telling me that now they're doing some like food introduction stuff because it's part of their role as breastfeeding dynamics. Which is fine by me. Like if you're helping a mom try to figure out, well, when do I breastfeed and provide opportunities to eat?
Yeah. From
That's
like a
cool.
developmental. Yeah.
But then if you're actually like getting your hands dirty with food and like seeing more red flags of like gagging and vomiting and oral dysfunction, like please refer on. If there's airway concerns, right? Laryngomalacia, coughing and choking, wetness during feeds, like, and maybe your initial tips didn't fix the problem. Like I would refer on. Would you agree?
Yes, absolutely. And I would say that's what I love actually with the dynamic that I have right now. Like you said, this bubble of IBCLCs I get to work with. They're lovely. But when people reach out around, because people, as you know, they reach out from around really the world at this point. And, that's when we're looking like, who do they have in the area? Who can they work with? Is it an IBCLC, an SLP, an OT? Sometimes it's like, they don't have any of those things. They're having to really travel to find care. That's where it can be really tricky. And
finances.
Yeah.
Right? Because you said it yourself, I'm private pay. I'm out of network. I will help you get it covered as out of network, but I can only do so much. From that standpoint, because I want to be able to provide good quality care that my parents need. And I can't do that if I'm seeing 40 kids a week.
So for these people that are listening that are like, yeah, that's me, I'm far away, how can I get some support? How can they find more information from you? You have a podcast, you have resources on your website. Share some of that with everybody before we sign off.
So again, my name is Jean Hawney. I am the owner of Little Eaters and Talkers. My website is thelittleeaters.com. On there, you can contact my team. We schedule everything on our online platform. Sometimes you have to contact us to book if there's certain times and days that you're looking for. But we're pretty organized. We get to everybody. If it's not a good fit or it just doesn't work with our times, I will really personally do my best to find someone either in your area or another provider that can help you. And oftentimes I say this, like, your baby is my baby. So if I'm involved in your care, I can be a little overbearing because now it's my child. So I'm preparing you for that, right? Because we love our patients.
And I think it's always important to share that. Like, not every provider is going to be the right fit for the parent, and that's okay. Jean and I both have very strong personalities, and just know that. Like, not everyone's going to be the right fit. Like, we don't take offense. Go find someone else. It's okay.
Yeah. And I mean, you can disagree with me if you don't agree with something I say.
Yeah.
I'm open to suggestions. I think my biggest thing is like trying to prepare parents and remind them that slow and steady wins the race, Like these quick fixes don't normally work.
Yeah. So how can people find your podcast? What's it called?
Little Eaters and Talkers.
Okay, perfect. All right, guys. So you heard it. That is Jean. She is with Little Eaters and Talkers. She's here in the Houston area. I love working with her, referring to her. So please share this with a parent who would like more information. They're maybe dealing with bottle aversion, not sure what to do with feeding concerns. Please share this. Let's get this information out. And you know the drill. Please like, share, follow the podcast. If you can subscribe, it helps get this out to families everywhere who need this information. Thank you for listening. I hope you have enjoyed this episode of the MyoHacker Podcast. Remember, small changes can make big impacts on our overall health and well-being. If you enjoyed this episode, please take a moment to rate and review wherever you get your podcasts. This way, more families will learn about this important information and we can make a bigger impact. Head on over to MyoHackerSLP.com for in-depth resources and guides. You can also join me on Instagram at MyoHackerSLP for bonus content and demos. And if you have questions or topic suggestions for future episodes, send me a message. I would love to hear from you. Until next time, let's biohack myofunctional health as MyoHackers who change the world through intentional action and connection and breathing. Quick disclaimer reminder, the content shared in this podcast is for informational and entertainment purposes only.